I am Dr. Will Sanavasi of the Mayo Clinic Internal Medicine Residency Program. Today I will summarize our article on the organ transplant imperative, which is published in the June issue of Mayo Clinic Proceedings. To begin with some background information, in 2015, a record high 31,000 solid organ transplants were performed in the United States. The year ended with over 122,000 patients still on waiting lists. The number of transplants performed has continued to increase, with the demand for organs exceeding supply. Unfortunately, the substantial planning and effort needed for organ transplantation result in a commitment that's often burdensome for patients with severe organ failure and associated comorbidities, who would benefit from triggered goals of care discussions and early palliative medicine involvement. To understand the transplant imperative, it helps to consider several ethical paradigms that underlie the phenomenon of pursuing interventions despite potential threats to well-being. Chief among these is the treatment imperative, defined as the perceived need by physicians and patients to pursue interventions. Similarly, the technological imperative is the tradition of offering the newest care that is technologically feasible. With the modern emphasis on cost effectiveness, decisions made from a technological imperative may oppose the goal of providing indicated high-value care. Patient care is also influenced by therapeutic inertia, which is the adherence to a preconceived course of treatment, even in the face of new medical problems or new risks. The treatment and technological imperatives drive the pursuit of organ transplantation by patients with end-stage organ disease. Once the process of transplantation is initiated, the expense of time, resources, emotion, and planning can result in a therapeutic inertia that precludes consideration of non-transplant directed cares, even as a patient's clinical trajectory worsens. This unresolved strain between anticipating transplantation and discussing goal-centered care can harm patients. Among organ transplant patients, the perceived conflict between disease-directed therapy, consistent with transplantation, versus comfort-directed and supportive treatment can hinder a compassionate approach that would represent reasonable prognosis-based expectations and goals of care. We propose the concept of an organ transplant imperative, which is the perceived obligation by patients and healthcare providers to proceed with organ transplantation and to avoid advanced care planning, triggered goals of care discussions, and timely palliative medicine consultations, even in situations where patients' clinical trajectories have worsened, resulting in poor quality of life and low likelihood of meaningful survival. To illustrate the organ transplant imperative, we present the case of a 45-year-old man with multiple complications related to alcoholic cirrhosis. He presented to the hepatology clinic with altered mental status, fatigue, and hypotension, which required hospitalization. Prior to admission, the patient and his hepatologist had discussed the possibility of being listed for liver transplantation. Following admission, he was determined to have pneumonia, hepatorenal syndrome type 2, which has an estimated median survival of 3 to 6 months, and a MELD score on admission of 41, estimating a 70% likelihood of death at 3 months. During hospitalization, the patient vacillated between desiring aggressive, disease-directed therapy and transitioning to hospice. When asked what was most important to him given the severity of his illness, he identified spending time at home with his family and new fiancé, and minimizing or even eliminating admissions to the hospital. After much discussion, he was presented to the Institutional Liver Transplant Board. Due to concerns regarding his substance use and support system, he received deferred status. The patient, his family, and members of the healthcare team expressed frustration with this situation because it presented the hope of listing him for transplantation but no commitment to do so. Furthermore, the patient was torn between the possibility of receiving a transplant and information from his medicine team that his prognosis was poor and that exploring symptom management and end-of-life care would be a realistic and compassionate approach. The patient was eventually stabilized and discharged from the hospital. In outpatient follow-up, his MELD score further worsened and his performance status deteriorated. Within 6 weeks, he was readmitted to the hospital. Aggressive disease-directed measures were ineffective. Ultimately, he was transitioned to hospice care within 24 hours of passing away. This case illustrates how a combination of patient, provider, and systems-based factors resulted in failure to deliver advanced care planning, reassess goals of care at the pivotal point of patient decompensation, and provide early involvement of a palliative medicine team. A critical juncture occurred when the patient, despite his terminal prognosis, received deferred status for liver transplantation. If the patient had been denied a transplant, then he could have been released from hope of a longer life, and meaningful end-of-life discussions may have occurred. Conversely, the patient felt compelled to pursue medical intervention and transplantation and to decline comfort measures. Furthermore, the hepatology team was determined to recommend strategies to maximize his chances for being listed for transplant, while the medicine team was obligated to label the patient's high mortality risk and offer hospice, and the patient was caught between these two perspectives. We believe that this combination of factors, specifically when considered through the lens of organ transplantation, illustrate the organ transplant imperative. Strategies for discussing and resolving the transplant imperative are critical to providing compassionate, meaningful care to patients with end-stage organ failure, regardless of their candidacy for receiving a donor organ. Although there are no formal recommendations regarding triggers for end-stage liver disease, the current patient had had multiple hospitalizations, worsening performance status, hepatic encephalopathy, hepatorenal syndrome, bacterial peritonitis, and gastrointestinal bleeding, all of which have been identified as potential triggers for intervention by experts. When looking to the example of other diseases, triggered goals of care conversations have been shown to improve patient care and quality of life. In conclusion, the challenges of providing supportive care in patients with life-threatening illnesses are well defined. However, the organ transplant imperative is a new concept. We're hopeful that awareness of the transplant imperative will lead to improved understanding between specialists, generalists, and patients, and will provide opportunities for more formalized involvement of palliative medicine specialists in the care of transplant patients. Thank you for listening to this summary. We hope that you find our article on the organ transplant imperative to be useful.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.